Thank you. And we always will want to do a land acknowledgement at the beginning. So first of all, I would like to acknowledge that we operate on the ancestral and unceded territory of the Coast Salish people, including the territory of the Musqueam, the Squamish, and Tsleil-Waututh Nation. We recognize their ongoing contribution to the health and well-being of their community. I also want to express my respect and gratitude for the opportunity to live, work, and serve on this land because of them. It is crucial that we honor and support the rights, culture, and history of Indigenous people as we work towards reconciliation and improving healthcare services for all of us here. So yeah. And without further ado, thank you again, everyone, for coming to the seminar. It is about optimizing maternal and newborn health in the digital age. Before we start, I would like to introduce our 4 amazing speakers very quickly. So first, Kyla Pongratz is a senior clinical leader on the provincial health system team within the provincial digital solution portfolio at our PHSA. She's also a registered occupational therapist, deeply rooted in clinical practice, and brings a wealth of experience in model of care transformation, innovation, clinical service delivery, operations, and health system. Kristen Korns. Kristen Korns is a senior leader for provincial education at Perinatal Services BC. She's also a registered nurse by background and began her career at our own hospital, BC Women's Hospital, NICU, back in 2000. She's interested in creative and innovative approaches to support learning, quality improvement, and change management initiatives. So with the PSBC, the Perinatal Service BC team, she has worked on creating the Perinatal and Newborn Health Hub, which we will later on dive deep into it. It's a provincial resource for all perinatal healthcare providers. Our second speakers will be Marianne Vidler. Dr. Marianne Vidler is an assistant professor in the Department of OBGYN at UBC. Her research focus is on pregnancy complications and maternal mortality in resources-constrained setting. Her research focuses on community knowledge, attitude, and practices related to pre-eclampsia and obstetric care in South Asia and Sub-Saharan Africa. Marianne is dedicated to positioning our Vancouver as a leader in global maternal and child health. Our last speaker will be Dr. Elizabeth Keys. Dr. Keys is an assistant professor in the School of Nursing at UBC. She has a clinical background in community and public health nursing, focused on promoting child and family well-being in the community. The goal of her research is to promote and maintain infant and parental and maternal mental health by supporting parent-child interaction and sleep health. In her research, Dr. Keys examines how innovative approaches and models of care, such as e-health and precision health, can be leveraged to contribute to sustainable health services transformation that result in real-world improvement in the lives of families. Okay, I think I talked too much. So without further ado, let's welcome our first 2 co-speakers, Kyla and Kristen. I'm gonna stop share my screen. Okay. Kyla and Kristen, you can start share your screen.
Thank you.
Looks great. Can see your slides.
So we're very grateful and excited for the opportunity to be here and share this project with you all today. So if you can imagine for a second the previous state for perinatal and newborn health professionals in the province of BC, utilizing various sites and resources to deliver care, having to pay memberships for different organizations to access guidelines or clinical support, and arduous login processes. We've all been there where we can't for the life of us recall a password, but you have a special character. So finding resources isn't always easy when you really need it. Imagine again the next generation, the Perinatal and Newborn Health Hub, or the Hub, an online resource system aimed at making up-to-date, evidence-informed clinical information available on any device, anywhere in the province. The Hub vision is to offer accessible clinical information to all perinatal and newborn health professionals that is current, succinct, and easy to use, while also providing an opportunity to learn more with links to references and resources that can be shared with peers to support the provisioning of high quality standard care for pregnant women, their newborns, and families. Are you having a hard time hearing me? Okay, I'll speak louder. Is that
Yes,
better?
some audio mentioned the audio, so it's
Okay.
a little bit low.
So Perinatal Services BC, or PSBC, provides leadership, support, and coordination for the strategic planning of services from preconception to the newborn period and is the central source in the province for evidence-based perinatal information. There are approximately 20,000 perinatal and newborn health professionals across BC, supporting approximately 40 to 45,000 births annually within the province. With this project, we had aimed to reach and provide support and clinical guidance to all these providers, whether they work in public health, acute care, primary and community care. In rural, remote, or urban settings, the Hub is designed to be the one-stop shop. Within under a year of its launch, we have exceeded 45,000 users, more than double our intended numbers, which shows there is not only interest, but a need to support professionals in this specialty area. Throughout the development process, the Hub has used these three guiding principles: a high degree of engagement with various partners and end users, taking an iterative and interactive approach, and doing incremental and rapid prototyping based on partner feedback, ensuring user stories drive the development and the design of the Hub. What was really exciting about this project was how these guiding principles truly facilitated exceptional engagement. As Kyla will mention later, through initial focus group, content writers, engagement sessions, external review groups, beta testing workshops, and orientation sessions, we were able to find creative avenues that generated anticipation and enthusiasm throughout the project.
So the Hub project officially began in June 2021. To ensure the Hub would meet the needs of clinicians and provide real value, we conducted surveys, interviews, and workshops. This collaborative process helped us develop and refine the comprehensive list of requirements through multiple engagement sessions with end users, the Hub Advisory Committee, and our internal team. Our efforts included working with consultants and web developers to prototype these requirements and design the Hub. By April 2023, we received our first prototype, and since then, we've continued to refine and update the site. The Hub officially went live on October 19th, 2023, and then was released to the public on November 29th. We are now focused on sustainment planning and ongoing quality improvements to ensure the Hub's continued success and effectiveness. Following the initial release of the site's early iteration, we embarked on a thorough site testing phase. We integrated feedback sessions into existing partner meetings and organized a series of engagement activities. These included interactive demos conducted via Zoom and Teams, supplemented by small breakout rooms with multiple facilitators to ensure effective discussions were held. Clinicians engaged with 4 clinically focused case scenarios and participated in surveys to provide quantitative feedback. Additionally, we collected qualitative insights through discussions in the breakout rooms. The feedback from over 100 clinicians across the province was meticulously analyzed, prioritized, and relayed to the web developers for implementation. Approximately 6 months later, after significant site and content development, we sought further user feedback through additional in-depth clinically focused case scenarios. This time, we reached over 60 clinicians who signed up for one of the 4 sessions offered, and this subsequent round of feedback provided invaluable insights for further site enhancements.
The real centerpiece of this site is the evidence-informed educational content guidance. Our team is developing more than 120 clinical topics for healthcare providers. We've written and loaded 80 topics so far. And the process begins with clinicians from around BC researching and writing topics. They then undergo a rigorous review process, starting at PSBC by our interdisciplinary clinical reference group. Then groups of 8 or more interdisciplinary external reviewers from all over BC meet to discuss and critique. And final approval happens back within our team to ensure relevance for the various healthcare settings across the province. Now that the hub has launched, we will maintain and regularly update the topics every 3 years or sooner, or as new evidence comes up.
Now we're going to show you a brief video on the hub.
Welcome to the Perinatal and Newborn Health Hub, the one-stop shop for all healthcare providers to access clinical guidance and resources. We've created over 100 unique, evidence-informed clinical care topics that capture all phases of the pregnancy continuum, from preconception through to postpartum and newborn care. No matter where you are on the site, you can easily navigate to find the clinical information you're looking for in just a few short clicks. From the homepage, you may choose to use the Continuum of Care filter by clicking through the relevant phase of the pregnancy journey, or from the main navigation bar by hovering over the various sections. You can also search using the main search bar on the homepage. The clinical care topics are written by clinical subject matter experts from across British Columbia and undergo a rigorous interdisciplinary review process with urban, rural, and remote representation. Each topic has a short introduction and key messages that are listed numerically for succinct, evidence-informed clinical guidance, with more detailed information found by expanding each key message. Within the expanded key messages, related clinical care topics or relevant clinical resources have been hyperlinked for ease of navigation across the website. You will also see a red icon to share, save, or print a topic. Further down the page, there is supporting evidence, provider and patient resources, as well as the extensive list of references used to create the topic, and a section for acknowledging BC subject matter experts who supported the development of that particular topic. There is also an opportunity to provide specific feedback or suggestions on a topic you're reading, or email us at hub@phsa.ca. There is also the Professional Resources section, where practitioners can access practice guidelines, practice resources tools, and algorithms to refer to in their practice. You'll find that we've created a suite of new resources and tools for clinicians to access. Back on the homepage is featured content, in which we have an opportunity to showcase content or highlight new practices or events. There is also the Cultural Safety and Humility page, carefully designed by our provincial lead for Indigenous health. This section consolidates national and provincial Indigenous health resources, offering definitions, practice frameworks, and educational materials to help healthcare providers understand and combat Indigenous-specific racism. A section for virtual clinical support, accessed from the top of any page, helps providers access real-time support for questions regarding clinical decision-making and patient transfers. The education section of our website provides information and resources on various education programs for healthcare providers, as well as an additional learning section, with courses and webinars to support professional development. The Hub also features extensive access to screening programs, information and resources, including the EDD and Trisomy 21 calculators. While you do not have to register or log in to access resources and clinical guidance on the Hub, doing so offers the ability to create libraries and save your favorite resources for quick and easy access. You can also share libraries that you have created with colleagues or students. This is the unique feature of the Hub. Thank you for visiting the Perinatal and Newborn Health Hub. If you have any feedback about the site, or if you have any questions as you familiarize yourself with it, please feel free to email us at hub@phsa.ca.
Okay, so as we conclude our section of the presentation, it's important to recognize that both our achievements and our ongoing work ahead. So while we've made significant progress with the Hub project, there's still much to be done. First, we'll focus on developing a comprehensive maintenance and sustainment plan. So although sustainment planning often comes after the initial project phases, it's crucial for ensuring the long-term success of the Hub. We aim to establish a solid foundation that supports continuous growth and optimization. Next, we are committed to enhancing equitable care delivery through the Hub. To this end, we collaborated with the Provincial Health Services Authority Diversity, Equity, and Inclusion team to co-create a dedicated diversity, equity, and inclusion landing page. This page is currently in progress. Increasing awareness of the Hub is also a key priority. By expanding our marketing and outreach efforts through conferences, presentation, and word of mouth, we aim to ensure that more users benefit from the Hub's resources. And then finally, understanding the value and usage of the Hub is essential for its ongoing improvement. So we are working closely with our evaluation and web development teams to optimize our data and analytics, allowing us to continuously refine the Hub based on user feedback and usage patterns. And with that, I believe we are done. Do I just hand it over to Marianne?
Marianne, you can start to share your screen.
Yeah. Okay. Here we go. You can see this okay?
Yes, perfect.
Great. Okay. Thank you very much. All right. So thank you for the invitation to speak here today. I'm going to take a little bit of a different journey than our last presenters and talk about a research study that hopefully will have some kind of early preliminary findings that might be useful to this group. So the study I'm going to talk about is PAC study for short, or postpartum screening for anxiety and comorbid conditions. Oops. Okay, there we go. This is lots of names on a slide, but really the point here is just to say that I'm here on behalf of a large team, a number of groups, organizations, health authorities, our funder, of course, and some of them are presenting today and also attending. So just want to acknowledge that here on behalf of a large team. So just to kind of situate us to this topic that I'm going to go into, which primary focus is on postpartum anxiety and the postpartum period. Just to remind us all, although I'm sure you all know, after delivery, patients are at risk of both short and long-term health issues. Some of those are persistent pain, particularly after cesarean deliveries, infection, anxiety with very high rates and not good data on that actually, and depression. And also, of course, we know these risks are not evenly distributed amongst our BC population and that some groups are at higher risk. Despite this, what we think is an important need, there isn't currently any infrastructure in BC to allow simple systematic collection of really patient-reported outcomes on any topic at a population level, but in particular, our interest is here in the postpartum period. And the other unique thing in this group is, as we know, people in the postpartum period might be difficult to access for a number of reasons. There may be unique logistical issues, obviously time, difficulty traveling, and as always, but in particular at this time point, we need to balance survey fatigue, access, as I mentioned, time constraints, as well as the limited healthcare resources that we may be recommending as a result of screening. So with that in mind, we developed the following study, and the primary objective really was to assess the feasibility of using an online platform to screen for a number, primarily mental health, but a number of postpartum conditions, and to see if that was feasible. Secondarily, we hope to be able to identify some characteristics that might predict a higher likelihood of a positive screen, as well as common comorbidities that might cluster together. But primarily, this is really a feasibility study. So I won't go into much detail about the project itself, although I'm happy to answer questions, but it had a few components. One was, the primary component was the 7 online questionnaires, which I'll show you in a minute. We also offered participants to answer the system usability scale, which some of you may be familiar with, as one of our approaches to try and assess this feasibility. We also sent out a follow-up survey for those who indicated they'd be willing, very brief, less than 5 minutes, 4 weeks after study completion, to see if they were provided any clinical recommendations, how that was interpreted and what action was taken. And then finally, we are conducting 12 to 15 interviews with participants to get better in-depth understanding of their experience doing the online screening, their acceptability of the process. So as I mentioned, here's a list of the questionnaires that patients complete. These relate to anxiety, depression, social support, anger, sleep, pain, general quality of life. Okay, one other thing I wanted to mention that I thought might be of interest to this group is we're also using a number of recruitment approaches or outreach approaches to engage potential participants. And we thought this was really important because we're not going to be able to provide much useful recommendations if all of our participants are of particular demographics or regions. And what we really want to be able to say is if this is a feasible approach across the province and for a variety of groups. So to that end, we've been using social media, paid and unpaid, partner websites, including Reach BC, which some of you may be familiar with. We've put posters in community locations as well as hospitals and clinics. We are doing some in-person recruitment at St. Paul's. That's been ongoing for several months. Surrey was ongoing, then we took a break, and now we've just started back up and soon to launch at Royal Columbian. And we've also been doing text message approaching at BC Women's and St. Paul's. So now I'm happy to share some very interim results because we are still in the data collection phase. So we're at about 260 participants of our total sample size of 550, but I think that there's still some useful tidbits that we can see. Okay, so first just wanted to give you a few pieces of data to get a sense of, are we doing a good job at getting representation? And I would say it's okay. Luckily, we still have quite a number of participants to go, so we're going to hopefully continue to improve on this. You'll see that the population is quite highly educated, definitely predominance of English as the first language, although there's a range of others. We do have ethnicity data, but it's a little bit messy and I didn't have time to really clean that up nicely. I would say we do have variety, but still heavily white European participants. So that's still something we're working on. I'd say better representation of rural between urban and rural and urban, as well as here, this is the site of delivery. So you can see we actually, although there's the vast majority from BC Women's, and largely that's because we've been doing text-based recruitment there for the longest, but we do have a pretty good smattering of sites across the province, and many who deliver at BC Women's also may come from regions outside of Vancouver. So I'm optimistic about some of this. Then just a few delivery characteristics. So we also want to see how this represents the general perinatal population of BC. So 38% had been pregnant before, 13% indicated their pregnancy was unplanned. I think it's interesting that about a quarter indicate that their delivery was traumatic, which I think speaks to the need of doing screening at this time point as well. And then if we look at mode of delivery, good spread of cesarean deliveries, a little bit under half, and then mostly vaginal unassisted and some assisted. Okay, so now into some of the feasibility data. So primarily, we're going to look at that through completion rates and completion time, but I put a few other markers on here that might be useful. So When asked if they would like to know their survey results, so we offered, for the validated questionnaire that provides scoring, we offered to provide that to participants if they choose, and the vast majority did want to see that data. 82% wanted to receive study progress updates, which I think is interesting because I think that's not typical in research. Although we talk about it a lot, we actually don't usually on an ongoing basis provide these updates, but really participants do want it. And almost all would be willing to be contacted for future research. I mean, again, this is people who are already participating, so it's, you know, not a general population, but I think that's encouraging. So it's a little bit messy to look at completion rates because we did struggle with getting some fake participants, which we've had to do a lot of quality control to weed out. But of those that have made it through, the completion rate is very high. We were looking to see that most had completed 70% or more, but those that are starting, almost all are completing in its entirety. And we had also estimated much longer the survey would take, and it's taking about 26 minutes, which seems to be a reasonable length of time based on completion rates. And then just back to the recruitment, for those of you who might find this useful, this is how participants heard about the study. So the text message has been very successful. Again, we've been doing it for longer. Not everything was started at the same time, so that's important to keep in mind. But many through social media, particularly through paid ads that we used. And then I expect the number of those being approached will increase. But often we rely on the bottom three, like websites, study posters, and those are, like, by and large, not where people are hearing about the study. So we know that that's a challenge if we rely only on those. As far as usability, this was the purpose of including the system usability scale and then also the participant interviews. So far we've done 9 of our hopeful 15 interviews. That was done in the spring, and then we'll do another set before the end of the year. And of those who were asked, 63% were willing to complete the system usability scale. And here we wanted to see that most participants were 70 or higher on their score. And as you can see, the median score was 80, and 84% scored 70 or higher, which is kind of deemed acceptable. And none scored under 50 to say that the system was unacceptable, and very few in that other bottom category. So again, that's encouraging, although I wouldn't take this on its own. This might be a little bit tricky to read, but this just kind of breaks down the system usability scale as well as the responses. And I mean, I think that the message is really the same as the previous slide, that overwhelmingly it was positive, although certainly there are still areas for potential improvement. Okay, one last bit of kind of results. So we also invited participants to complete a follow-up survey if they were willing. So we've sent out almost 200 surveys at this point, and more than half have been returned, which I'm pretty happy with. And this was to ask about those recommendations that were provided. So around 60% were recommended some sort of follow-up as based on their responses to the questionnaires. And so we wanted to know, did they actually do that? So we can provide recommendations, but are patients going to trust that data? How does that relate to getting it online and not from a healthcare provider and these types of things? So when asked, about 60% were recommended follow-up, and about 60% in fact did contact a healthcare provider. And you can see that was through a variety of providers, although mostly GPs. And then you can see what happened as a result. I'm sorry, the quotes are quite small and probably hard to read, but you get an idea. So many were then provided treatment, some got additional screening or referral, and then a small number didn't have any action taken. And then for those who didn't, we wanted to understand why. So there's a range of reasons, but most said other, and that's kind of those quotes that you see there. And again, there's a variety of reasons, but many relate to already being in care or having a plan. So I think this is some really interesting, rich data that we're getting here. And, it's important to note that 5 said they didn't trust the results, or 3 that they didn't feel their healthcare provider could help. But the majority, that was not the reason that they didn't contact or follow recommendations. I think one last thing. So next steps, of course, is to complete our recruitment, conduct our data analysis, which at that stage, we hope to assess the feasibility and usability amongst some of these subgroups, particularly those that self-reported a mental illness, had premature delivery or other pregnancy or delivery complications, as well as traumatic delivery, to see if a system of online screening like this would also be appropriate for that group, as well as different demographic characteristics, and ensure that actually does reflect our BC population. With the ultimate aim, we hope to inform some targeted screening approaches and identify those who might be at greatest risk and any clustering of these comorbid conditions. So I think that I'll stop there and happy to take questions at the end. Thanks very much.
Thank you, Dr. Vidler. We do have some questions, but we will save that later on. We'll let Dr. Keys to present first. Thank you. Looks good.
Great. So thank you, everyone. I'm really interesting to hear the presentations before, and I'll just wrap things up with talking about promoting and supporting sleep health in families of young children in the digital age. Thanks to Sally for the land acknowledgement before. I'm actually coming from the Okanagan, which is located on the traditional ancestral and unceded territory of the Syilx people. And I'd just like to acknowledge myself as a white settler who's benefited from living and working in a healthcare system that has done much harm to Indigenous people, as really highlighted in the Plain Sight report. And one part in particular stands out to me is the judgment that Indigenous people experience as parents due to that bad parent stereotype. And so this is something that in the work I'm describing and in my future work, I really strive to do my part to do better and promote more supportive systems. So why sleep? I think if you don't have it, you know why. But if you haven't had a lot of experience in the parenting sleep world, it's something that you don't really miss until you don't have it. So this is some just descriptive statistics of a secondary analysis that we're conducting right now from the pregnancy during the pandemic cohort, which is a really large Canadian cohort of babies born during the pandemic. And they continue to follow up. I think they have 3 or 4 year data now that they're working on. But you'll see more than half of parents report some sort of problem with sleep at 3 months, and then again or just under half at 12 months. And so most of it is mild problems that people or parents are saying they're having, but there is some about 10% that having moderate or severe. So it's in terms of a parent priority, it's a pretty big priority. There's been lots of research done on kind of connections between infant sleep and development. And so kind of poor sleep quality, duration, more fragmentation is linked to lower kind of attention in preschool children, poor cognitive development outcomes, poor emotional and physical health. And what's interesting is, if children are having escalating sleep problems from birth to age 5, so that they don't necessarily just go away, or they don't necessarily all grow out of it, they're also more likely to then have difficulties at school. And then on the more experiential side of things, this is another reason why I do research in this area. This is a quote from a parent that reached out to me and was just describing how tough it was being a parent, and just feeling strongly that infant sleep and information about it is really important because they don't know how and why would they, highlighting the fact that, you know, despite buying books and books and trying to get a lot of other information, they're still kind of having these issues. And then also highlighting this feeling of guilt in terms of, you know, I've created the problems myself, which I think is speaks to some, you know, some feelings of judgment and not feeling well supported. I mean, that plus mixed in with all of the products that you can buy and information and books, and you can create, you know, reinvent the womb if you have enough money. You know, I think it's a hard time in the digital age to be a parent with all this information. And so early in my research kind of career, I was part of a study that asked families what they wanted research, families who were expectant parents or parents of young children. And one of the top 10 questions that they came up with was, how can sleep problems be prevented, assessed, and treated in culturally appropriate ways that's really tailored to individual families? And so this has really guided a lot of my my work. I started off doing an in-person intervention. So my background's in public health and community health nursing. And so this was like home visiting type of intervention that we combined kind of coaching in reading your baby's cues with some information and anticipatory guidance about sleep, and did a study to evaluate that. Parents did report less nighttime wakefulness. So the baby was awake during the night less. And we actually did see improvements in maternal depression scores. But parents also, when we qualitatively asked them, described experiences of that information overwhelm. So being overwhelmed with all the different opinions and information on sleep. They highlighted that learning about the cues was really important. And because this intervention was delivered to mothers and fathers together, one of the things that they highlighted was really helpful was working together as a parenting couple and having that opportunity for father involvement. But it was probably too much information all at once for the intervention. It was too little doses, so probably needed to spread it out a little bit more. And it was delivered probably too late, because by 5 months already, we could see that families were immersed in sleep problems and they had significantly lower quality parent-child interactions with their child. And so you kind of had to work a little bit harder to come out of that. So this slide kind of represents a little bit of a winding road to figuring out, you know, how can we take an in-person intervention and figure out how to leverage some of the supports and great things about more digital interventions. And so I've been involved with a few other studies in terms of taking online pediatric behavioral sleep program, Better Nights, Better Days, trying to figure out how we can adapt it for use for parents of babies. Also involved in kind of a health promotion, ABCs of sleeping, kind of checklist or self-assessment for parents with recommendations to key kind of healthy sleep habits that they can work on. But all of that's kind of brought me to developing the slumber program, which I'm like to talk a little bit more about now. And so the slumber program kind of really builds on the play to sleep or intervention that I described about the home visiting, but trying to figure out how we can leverage some digital technologies so that we can, you know, make it more cost effective, make it more accessible, etc. And this is a model that we're using to kind of guide the development of it. And so right now we are in kind of phase 1, phase 2, kind of design and testing is planned for phase 2. And I'm just going to share a little bit about what we've done to prepare for that. So first, last summer, we conducted an environmental scan of online Canadian infant sleep resources that were specifically targeted to parents. These are resources that were developed specifically by Canadian Health and Social Services organizations. And so we used customized Google search engines, sorted through about almost 2,000 resources and narrowed it down to 128 that met the inclusion criteria. And then for that, what we did was we used the CDC's Clear Communication Index to kind of code the resources. So these were downloadable resources or PDFs or websites for parents that had contained information on infant sleep. And so it was really interesting. In terms of the communication clarity, it's quite a high cutoff, but only 6% of the resources that we looked at met that cutoff score of 90 or above. And most often that was due because the resources lacked visual supports or didn't have clear messages or call to actions and didn't really present information about risk. And the information that we're looking at could be anything on infant sleep. So it could be safe sleep, or it could be, how to get your baby to sleep better, what to expect, that sort of thing. Then we actually looked at a content analysis of just the resources that focused on information about infant sleep, not necessarily SIDS prevention or safe infant sleep. And so we found less than half of the resources had information about the sleeping part, the behavioral part of sleep. Of those, most often they were focused on anticipatory guidance and talked a little bit about baby sleep needs, developing bedtime routines. There's really some common information parents were getting. And then less so infant feeding and sleep, how to deal with night wakings and getting baby back to sleep, and how to soothe and settle infants. So that's an important part of knowing what's already out there. And then this next part, what we launched and just wrapped up earlier this year was a co-design workshops with parents and providers. So we had a total of 48 participants. And what we asked them, we walked them through kind of a workshop of, what would you like in an infant sleep kind of program or support, and we kind of narrowed it down to top 10, a list of top 10 behavior techniques that they would like to see incorporated into that. So we included both quantitative survey and more discussions in these workshops. 100% of participants really wanted the program, if it was going to be online or virtual or digital, to be mobile friendly, but it didn't necessarily have to be an app. There should be summaries, activities, and examples, a troubleshooting section, step-by-step action plan, and videos incorporated. And then engagement features, and the engagement features that people told us they liked the most was kind of trackers, schedules, or calendars, and a community forum. And then this really highlights some of the qualitative discussion that we had with folks in terms of making sure for the information and topics that we covered, that there's foundational information on sleep. There is information about factors that cause differences or changes in sleep, culturally relevant resources and information was highlighted as a need, as well as when to get more support or more information, and the possibility of having some sort of referral kind of system booked in for when people needed to get more help. Credibility, scientific info was important to include, as well as how to identify who is a sleep expert, because lots of people say they are. And then also coping resources and supports for the caregiver. And then in terms of the formats and features, really mirrored some of the quantitative kind of survey findings. But different versions or options, so not a one-stop shop, which really aligns with kind of the personalized approach we're hoping to include, and then really prioritizing accessibility and inclusion, and making sure that caregivers are not feeling judged. We did talk a little bit about barriers, like facilitators and barriers. So again, that non-judgmental and flexibility comes up, as well as the credibility. But then parents also highlighted that, accessibility was important. connections to health professions and organizations would really help it be known and be found out. Barriers that people mentioned was, remember that if this is a sleep program, parents are really tired, but we're also really busy. And so, short sessions that start early, offer reminders would be really important. Making sure, again, that information and the program would be personalized so that it would meet families' needs, so that they're not having to wade through a bunch of information that's not appropriate for them or relevant to them. And then, also trying to get away, because sometimes with sleep, it changes a little bit more slowly than people would like for their babies. And so that lack of immediate progress might be a barrier as well. So from that, we've envisioned the slumber program to kind of be a stepped program that's kind of divided up into early infants and later infants, and kind of builds on more and more complex strategies that are typically evidence-based. It's just hard for people to implement on their own. And then as people kind of need a little bit more supports, then they might move from an asynchronous self-led module into maybe some hybrid contact with a provider or a support worker. The next step for us, now that we're kind of working on developing the low fidelity prototypes, which walks people through kind of an assessment, and then trying to figure out what they would like to prioritize as low or high priority, offering them kind of a personalized portfolio, and then launching them into connecting them through those different modules or portfolios based on what their preferences and their needs. And so the next phase of our work will be to do preliminary refinement, for the young and the older infant prototypes. And so we'll do a series of iterative kind of sessions with parents. And then once we have that refined a little bit more, we'll be working on a proof of concept testing, and then pilot testing. So I think that's all the slides. Just like to say a thank you to, I think as Marianne said, it's, lots of people coming together to do these projects. And so these are kind of some of the key people in my lab. And when you're in the Okanagan, you get to go to Okanagan Lake for your lab meeting. So that's a picture of our team right there. So I think I will hand it over to Beth and Sally, or hand it back to Beth and Sally for the question period.
Thank you so much, Dr. Keith. That's fantastic. So yeah, we have 10 minutes for the Q&A. Oh, I saw someone raise their hand. Please go ahead. You should be able to unmute yourself now.
Yes, thank you, Sally. And this question that I have for Dr. Elizabeth Keys, and it's that infant sleep is really disturbed, and there are many people who just simply don't know who to turn to and what resources are available. And I currently face the same problem in my own home. And the only thing that I was left with, the only thing I could do was search for these sleep therapists. And of course, they're really expensive. But when you have no choice and you're suffering with lack of sleep, that's the only thing. So and they're very, very expensive to pay these sleep therapists. It's not a little bit of money, it's a lot of money. So what do you recommend for people who are having infants who just will not sleep?
I think this is a really common experience, and really highlights the need for more accessible and visible supports. And so one thing that, I know, in terms of individual cases, I can't comment on, but something that I try to encourage people to do is to go back to their primary healthcare provider, and try to work with them, because they do typically have a little bit of information on this sort of thing and can help you. Psychologists are another kind of option that can do. The sleep consultants, I think are, really demonstrate the need for support, but there's not universal kind of credentials or training in that. So sometimes those folks will be a healthcare provider, so they'll have a healthcare designation and they're a little bit licensed or registered, and so that can be helpful to check if you are. But primary healthcare provider or public health nurse or community health nurse sometimes can offer supports, as well as parent support workers at like parenting agencies.
What are these parenting agencies? I haven't heard of them.
Well, in Kelowna, we have like the Bridge Family Services program. So they often have programming for early childhood or postnatal supports. I think one more in Vancouver area is Pacific Postpartum Community Members, but I think that's why, yeah, like your primary care provider or public health nurse would be able to probably have information, and maybe even at some point the Perinatal Services BC Health Hub will have information on where to go to for community supports as well.
And that kind of ties into what I wanted to ask as well. There's been a number of questions in the chat, and thank you to Marianne and Kyla and Kristen for answering the ones in advance. One of the things I wanted to ask Kristen and Kyla is just about the future of this. We had done a research agenda setting project. Marianne, Sally, and I were all involved in it, and some folks from PSBC with patients to ask what they want to see in terms of digital innovation in the perinatal space, and kind of an equivalent platform to what you have, but for patients, was one of the highest priorities, and something that would support patient autonomy. And just thinking through all that incredible resources that you have, because the patient and the provider work together often to share decision-making responsibility. Have you thought through how to use this tool to support that process of shared decision-making? Can you talk a little bit about the future of the patient education part?
Yeah, we're actually in progress of developing a patient learning center. And it's very closely mirrored and aligned with the hub. So a lot of any patient resources that would be on that learning center would also be within the hub as well for providers to access. And it's a full curriculum from pregnancy up to newborn care, the early parenting and newborn care. So we've been using the same type of process, and it's been developed with digital lab. So it's very, and we're probably launching by the end of the year. And we're in the process right now of just getting to the beta model and start doing some beta testing. But it does have 4 learning journeys with several models within them. So pregnancy, labor and birth. I'm just trying to remember them all. And newborn feeding, as well as newborn care. So that is happening currently, and subject matter experts have been involved with that as well. Lots of LCs, lots of networks within public health. And so I can give you the name of the lead for that if anybody would like that. And or you can contact me if you have any questions about that. Because we're just in the process of developing that and getting it out to the public. And we have had a community advisory committee that has been involved since the start of that.
And hopefully some of the tools that folks like Marianne and Elizabeth are talking about developing could be integrated into that in the future as these really robust and patient-driven tools are developed across the province.
Yeah,
you know,
we
have a home.
Yes, score on the hub, and it is in different languages. However, we just learned that the translation isn't perfect in terms of the scoring part. So it's hard to get the actual number. And so we're working on that. We're just going to contact Mosaic, who is doing the translation for us, and see if we can get that sorted out, because we have about 12 different languages for the EPDS there.
We just have a couple more minutes, but I thought one of the things that came up in the chat that would be worth talking about is, Marianne, you've done this incredible job of really designing for inclusivity from the beginning, but the consequence of that has been this issue of bots or fake users. So can you just speak to that a little bit? Because I think that's a really great learning opportunity for the community as well.
Yeah.
Balancing those two things.
Yeah, I tried to kind of comment about that a little bit in the chat, but absolutely. So my own kind of personal agenda has certainly been around this equity and representation across BC of the research we're doing. Like, that's my personal kind of interest in making sure that we understand, the populations that we're most hoping to reach and serve. And so we tried lots of different methods, and as a result, we've resulted in some challenges, particularly with social media, which has been one of our best ways of getting, at least geographically, people outside of Vancouver. Part of that's probably related to my own personal connections in Vancouver, being where I'm based, that I have other methods that we're able to use there. But because you can target things, we get a lot of our interior, North Island through social media, but it has resulted in massive fake participants. Bots are relatively easy to weed out, but people who are just, inputting data to receive an incentive or for whatever reason is much more challenging. So it's been a very manual process. Within our big team, we've gotten a few tips and tricks about things, and I'm happy to share those, like, don't put the amount of the incentive on the poster, like just certain ways of organizing things that result in less. And we created an SOP for how to look through the data to flag which participants need, a deeper look. And then we did do individual follow-up by email to get their responses confirmed. Even with that, I'm sure people are squeaking through. And it terrifies me a little, because so much research is done online now for lots of good reasons. And, but it does terrify me to think that this is probably an across the board problem and it's really hard to catch them all. So I'm sure most of the people on this call have had this experience, but, yeah, Elizabeth's laughing, so I know she has too.
I guess that's the consequence. Incentives can work really well, but then be counterproductive too.
Exactly. And I think they're important, so we didn't want to change that. And we just accepted the downside, but that is a major downside.
Yeah. Unfortunately, we're out of time. And I know, Gurjit, you had your hand up again, but the posting of this recording will be on the WHRI Digital Health Learning Corner, and the speakers' names. If you want to get in touch with a speaker to follow up and discuss more, please reach out to Sally or I, and we can connect you. But thank you all for joining. As always, it's a pleasure to host these events and be able to bring this community together. And thank you once again to our wonderful, wonderful speakers who are doing such amazing work to support women's and children's health in BC.
For anyone that is still online, please just give me a 30-second, because we do have a next event coming. So I just want to share this quickly in case you don't know. Our next session is on October 24th. So invite a group of CEO and COO from leading health tech company to join us. You can scan the code here. Sorry, I'm taking this advantage to kind of promote the next one. I will post this on our chat box. And if you don't have time to scan, and that's all. Thank you so much, everyone, and especially thank you our speakers. This is a fantastic presentation, and we have a lot of questions, but just unfortunately, we run out of time. So feel free to reach out to us directly or watch our Learning Corner sessions, posted you have the link in the chat box as well. So thank you so much. I'm gonna end this meeting in 10 seconds to give everyone a chance to copy and paste the link. So, but feel free to leave, Kyla, Kristen, Elizabeth, and yeah, Marianne. Thank you so much. Oh,